linked to maintenance in a thyroid state for a long period of time. And the long anti-thyroid treatment has a positive impact on relapse risk by inducing long periods of euthyroidine and minimizing, again, the thyroid autoimmunity. So, how long should the treatment be continued to achieve remission? Probably there is individual susceptibility, but the primary treatment should be used for 3 to 10 years in children with continuous rather than cyclic anti-thyroid drug treatments. It's a very important message. I would like to emphasize also a particular form of a disease with a T3 predominant grave disease with persistent TSH suppression and clinical sign of hyperthyroidism. And the elevated serum T3 after serum T4 become normal or even low. It is a condition well recognized in adults, and the hypothesis is that type 1 and type 2 iodothyronine dehydrogenase are overexpressed in thyroid tissue. So in children, we demonstrated that also it could occur in about 13% of patients with grave disease. And the main characteristic at diagnosis between the T3 predominant grave disease and the classic type of grave disease is that there are higher titer level of serum TSH receptor antibodies, so higher severity of a disease at diagnosis with higher serum FT3 and FT4 concentration at diagnosis, and larger goiter size. And we have shown also that these patients require higher anti-thyroid drug dosage. You can see here the dosage expressed as milligram per kilo and per day in this patient. And you can see here that at baseline, we have used the same dosage, about 0.7 milligram per kilo and per day. And you can see that after 1 year, patients with a T3 predominant grave disease here in UAE required higher dosage than the patient with classic grave disease, more than twice higher at 1 and at 2 years, after 2 years of treatment. So this finding highlight the need to measure serum FT3 levels in patients with grave disease, particularly for those with persistent hyperthyroid symptoms with suppressed TSH and independently of FT4 level. So the question whether this patient demonstrated lower likelihood of remission in the long term remains still unknown. So the other option for treated patients with hyperthyroidism related to grave disease is the use of radioiodine treatment, which is safe and shown to be efficacious. It's widely used in mostly in adolescent patients with no late effect, but again should be avoided in very young children. Better to use after puberty, and it's not effective in case of very, very large goiter. The other option is the total thyroidectomy. It's also an effective treatment, but with higher complication rate compared with radioiodine treatment, and should be performed by a high volume surgeon. Also when the child is too young or has a very large goiter. So careful discussion with the parents and the child is required to determine the best choice of treatment between the long-term medical treatment or more definitive options such as radioactive iodine treatment or thyroidectomy. And large prospective randomized trials with long-term quality of life assessment is still required to address this issue in children. So what are the new therapeutic reasons for a cure of a disease? You can see that different options are on trials, acting on B lymphocyte immunomodulation, or blocking immunoglobulin recycling, or on TSH receptor signaling, or on immune tolerance. There are some trials going on this treatment, mainly with B lymphocyte stimulation with the use of rituximab. But we have no data on the long term. So the take-home messages, metimazole or carbimazole is usually recommended as the initial treatment and is generally well tolerated. Undetectable TSH and normal or low FT4, we have to measure FT3 levels because T3 predominant grave disease is important to recognize and require higher anti-thyroid drug dosage. Remission is achieved in only less than 30% of children after a course of treatment for about 2 years, and more prolonged anti-thyroid drug treatment may decrease the relapse risk and increase the remission rate to up to 50% after 6 years of treatment. And tell the parents the benefit and risk of anti-thyroid drug are still uncertain, and that they have the option of radical treatment after anti-thyroid drug treatment. So I will show you the algorithm we use for the management of these children with grave disease. At diagnosis, biological determination, with serum thyroid hormone levels, serum TSH receptor antibodies, and thyroid antibodies, thyroid ultrasound, and identification of possibly extrathyroidal manifestation of a disease, and treatment with anti-thyroid drug for 3 to 10 years continuously, but depending on initial severity and age. And after that, a trial of medication, and 2 possibilities: remission or recurrence of a disease. And if there is a recurrence of a disease, we should propose a definitive treatment, mostly with radioiodine, with after a drug treatment for hypothyroidism. And when there is a severe side effects, such as severe agranulocytosis or hepatitis, or non-compliance with drug, we should go more quickly to definitive treatment. But in any case, patients should have a long-term surveillance, and particularly during pregnancy for a woman. So in conclusion, the importance of maintaining a thyroid state by anti-thyroid for long term with prolonged continuous rather than consecutive courses of treatment has been emphasized to minimize thyroid autoimmunity and recurrence of a disease, and duration of anti-thyroid drug in children should be between 3 to 10 years, depending on the initial severity and the age at onset. And long-term therapy should be optimized by educational strategy to improve compliance. So what are the future research on the management? First of all, these results should be validated in over large cohort of patients. We have to improve compliance with drug treatment through educational strategies, to improve our knowledge of the long-term effects of a various treatment option concerning potential morbidity, to quantify on the long term the quality of life, to follow this population, particularly women, for the future pregnancy and outcome of the offspring. And a better understanding of the physiopathology should improve the option, remission rates, and patient management, and led to the identification of factors predicting the likelihood of remission. So to conclude, I would like to present to you a case, a clinical case. It is a follow-up of a child. I saw this this girl this week in my clinic, and it is I think it is a good example of how manage a very young girl with Graves' disease. So this girl at presentation had 5-year-old, and you can see the initial severity of the disease with very, very high serum FT4 and FT3. Sorry, it was a mistake here. It's FT3 level with very high TSH receptor antibodies. So we manage her with antithyroid drug treatment, and I will show you the results of this management. And you can see here the follow-up of this child, and you can see that she presented FT3 predominant Graves' disease. You can see here that after several months, TSH was always suppressed with normal FT4, but FT3 was very high. So here you can see here the management with carbimazole treatment, and you can see that we have to increase the dosage of carbimazole treatment. You can see here in milligram per kilo and per day at 1.2 milligram per kilo per day for several months or years. And we still continue the treatment. And here is the first 2 years of treatment. You can see here, after several years, after 3 years, we normalize the serum TSH receptor antibodies, and we could decrease the carbimazole treatment. And you can see here the continuous decrease of the treatment very slowly from 17 milligram per day to 5 milligram per day. And the treatment was stopped at 14 years old. So she has been treated for almost 9 years by carbimazole treatment. And now she is 16 years old, and she is still in remission with no TSH receptor antibodies. I think she is cured. So it is an example of a positive effect of a very long treatment with antithyroid drug treatment. So thank you for attention.
Thank you very much for a very nice lecture. Now it is the Q&A session. I think Professor Pat has a few questions for you.
Thank you, Professor Lee, for your excellent talks. My first question regarding your patient's example. I look at the data at age 6 years old. The patient received very high dose of carbimazole, up to 30 milligrams. That's very high dose for young kids.
Yeah, but you know, he has a T3 predominant Graves' disease, and to have a normal FT3 levels,
right,
we have to increase the dosage, and hopefully there was no side effects of the treatment. We know
right,
that most of the side effects occur during the first month of treatment, and with 1 milligram per kilogram per day, he demonstrated no side effect.
Right, but the side effect can occur later, sometimes many months or even years with high dose.
Yeah.
Higher dose has a higher side effect.
Well, yes, we know that side effect may occur later, but it is very rare. But if there is a strong side effect and a severe side effect, we have to go directly to radioiodine treatment or thyroidectomy. So we have no choice.
Okay. My second question about the antibody, thyrotropin receptor antibody. Do we know the major factors that modulate the antibody titer?
We don't know why some patient has very severe disease compared to other with less severe. It's the autoimmunity disease. Some individuals have a very severe form and other a more favorable form of a disease.
Now, you talk about data in children and adult. The treatment rationale for adult usually is about 2 years. For children, you recommend long-term, relatively long-term. So what's the mechanism behind this rationale? The difference between adult and children?
I think children have mostly a more severe disease than adults, and probably it's why they require more long-term antithyroid drug treatment compared to the adults. Yes, you are. It's true that adults have a remission rate after 2 years at about 50%, and children it's between 20 and 30% after 2 years of antithyroid drug treatment. So I think that children have had mostly more severe disease than adult patients.
I read your recent publication about anti-thyroid drug. Do you still believe that metronidazole or carbimazole has immunosuppressive effect to reduce the antibody?
I think by inducing euthyroidism, it may decrease the autoimmunity mechanism. So the drug don't directly act to the autoimmunity disease, but it is the return to euthyroid stage which contribute to reduce the production of TSH receptor antibodies. There is a question in the chat. Could you explain or postulate why Graves' disease patients with coexisting autoimmune disease have more favorable outcome in terms of Graves' disease treatment? We think that probably these patients turn into thyroiditis. And some of them have subclinical hypothyroidism in the long term. So probably it is the reason why there are a more favorable outcome in terms of Graves' disease.
Another question about if we read adult paper, usually the association between smoking and relapse of thyrotoxicosis or other oxidative stress related to the relapse of thyrotoxicosis. How about the oxidative stress in children?
I think we haven't data on children on this aspect of oxidative stress and the role of smoking in adolescence, for example. We don't have any data on that in children.
Another question, why very young children have more aggressive thyrotoxicosis?
Yeah.
In comparison with the post-pivotal children.
I don't know why, but it's true that very young children have more aggressive disease than adolescent children. And in France, there is about 15% of children less than 5 years old having grave disease.
During treatment of thyrotoxicosis, do you recommend monitor antibody, thyrotropin receptor antibody titer?
I think it is reasonable to measure every 6 months during the first 2 years of a disease, because probably it also reflects the severity of a disease. The time to normalize the TSH receptor antibodies probably is an important variable to predict the long-term evolution of a disease.
In your long-term treatment cohort children, for example, after 6 years or 9 years of treatment, how long is the longest when you follow after stopping medication?
We follow them for 2 years. After that, unfortunately, they are young adults and they are going to the adult clinics or to the general practitioner. So we don't have, and we need this data of the very, very long term, after 10 and 15 and years, what's happened. And unfortunately, there is no very long term follow-up of pediatric patients with rare disease, because after, I don't know how, at which age patient has to transition to adult clinics in Thailand, but in France, it's between 16 and 18 years old. So we miss this data.
So it's possible in this group of patients, when they become young adult, they, after stopping medication for 2, 3, or 4 years, become relapse thyrotoxicosis.
I think that the majority of relapse occurs during the first year after stopping treatment, or the first 2 years, and the rate of relapse after 2 years after withdrawal of the treatment are very, very rare. Very few patients relapse after 2 years after withdrawal treatment. So I think it is reasonable to follow them for 2 years after withdrawal of treatment.
Okay. Thank you. Any more questions, Professor Pairanja?
I think we have 2 more questions on the chat screen. Professor Leach, can you see?
Yeah. Did you see antineutrophil cytoplasmic antibodies induce vasculitis? Personally, I never see vasculitis in my clinics, but it is described in few patients after using the propylturacil treatment.
I myself have seen PTU-induced vasculitis, but a long time ago when PTU was used, maybe I think maybe more than 5 years ago, that we have to switch to, we have to change the mode of treatment to radioactive iodine or surgery in few cases. I think there's the last question too in French language, I think.
It's not a question.
It's not a question.
No, it's thank you very much for Jean-Claude Carrel and me for this talk.
All right. I have a question for you. In terms of treatment for T3 predominating grave disease, there are times that I can remember if you trying to suppress or decrease the free T3 level, then the free T4 becomes low, a little bit low. And I kind of okay with that by keeping free T4 a little bit on the low side, but free T3 normal. I'm not sure whether you have encountered the same problems.
So you have two choices, either to decrease the antiphoric drug dosage, or to add levothyroxine treatment. Personally, I prefer decrease very progressively the antiphoric drug dosage in order to avoid possible side effects because the drug, higher dosage of the drug. Personally, I prefer the dose titration, and it is recommended to use the dose titration with the lower antiphoric drug as soon as possible.
Okay.
So there is another question in the chat. What do you recommend to stop or continue antiphoric drug treatment in patients with euphorid using low MME dosage but still have positive? Yes, we have to continue antiphoric drug treatment, I think, independently of TSH receptor antibodies. And surely, if TSH receptor antibodies positive, we have to continue the treatment and not to stop, because the disease is always present.
You mean if even low titer? I mean, the question says that if the low MMI dosage, the patient is on low dose of MMI with the pressure of titer, but the titer is low.
Yeah. I think we have to continue the antiphoric drug treatment for several years after the disappearance of TSH receptor antibodies.
Okay, I got it. Because
most of patients have low TSH receptor antibodies after 1 to 3 years of treatment. And we recommend to maintain euphorid state for a longer period. So it's the reason why we recommend long-term treatment for 3 to 10 years after the onset of a disease.
Do you mean we should wait until the titer, the antibodies disappear, or less than 4 times the normal?
We should wait until the TSH receptor antibodies disappear, but several years after that.
All right, thank you. Because I remember, I have many patients who are on only 1 tablet of 5 milligrams of MMI. But then if you try to stop the medication, which is only low dose, just 1 tablet of 5 milligrams, then the disease relapse.
Yeah, it's the reason why we recommend now a very long treatment, and we can use even 2.5 milligrams per day of methimazole treatment.
All right, yes. And another question is that if you can raise an example in any situation that you have to use PTU instead of MMI in your real practice?
No.
In any situation like side effects?
No, I haven't the use of propylturacil unless in women during pregnancy. We prefer to use PTU rather than methimazole or carbimazole because of the teratogenic effect of a drug.
Thank you. I think Professor Pat has one more question.
Yeah?
One more question about, you mentioned about grape ophthalmopathy.
Yeah.
This group of patients is more severe than without ophthalmopathy. What's the mechanism behind this condition?
Mostly these patients with severe ophthalmopathy often have higher TSH receptor antibodies, and autoimmunity and production of a cytokine is higher than those patients without. And there are some, as you said before, smoking is also an independent factor to have a less favorable outcome on ophthalmopathy. I think it's the same in adults and the same in adolescent patients.
Have you ever seen severe ophthalmopathy in children?
It's very rare, but it could occur, and usually we have to use glucocorticoid intravenous treatment for several cures to treat them.
Okay.
And there is a last question in the chat. What is your recommendation for radioactive iodine therapy? Is the question concerned the dosage of radioiodine, or we use radioiodine therapy if the child has several years of anti-thyroid treatment and disease doesn't cure, or if there is no compliance to anti-thyroid drug treatment, so we use radioactive iodine in that case. And the dose of iodine is a function of goiter size, because there is a dosage, a particular dosage per gram of thyroid. So the weight of the thyroid is estimated by the radiotherapist to cure the child with radioiodine treatment. There is another question. How do you manage children who are incidentally found to have small thyroid nodules? If a nodule is very small, well, we have to propose a cytology examination when the nodule is at least 1 centimeter.
Thank you very much, Professor Leach, Professor Carell, and Professor Pat for the very nice lectures and the participation during question and answer sessions. Now, I would like to remind all the participants to please don't forget to fill in the feedback forms, which will appear as a QR code after closing remark. Finally, we come to the last part of our meeting. Let's all give a big thank you to Professor Carell and Professor Leach for very insightful presentations. I hope that you have learned and enjoyed the entire meeting. Before the end of the day, I would like to invite Professor Pat for closing remarks.
First and foremost, I would like to express my appreciation to both excellent speakers for providing valuable knowledge and experience, and all of you for attending this scientific program. I am confident that you find most up-to-date knowledge and management on CPP and thyrotoxicosis, which are invaluable for your clinical practice and ultimately lead to better patient care. The Thai Society of Pediatric Endocrinology will continue providing education in the next coming year, and I'm looking forward to meeting you all, hopefully face-to-face meeting by next year. Finally, on behalf of the TSPE, I would like to express my special thanks for Ipsen Pharmaceutical for their collaboration for educational support. Thank you all for joining us. Stay safe and take care. Have a good weekend. Goodbye.
Just a small word to thank you again for the invitation, and it was really a pleasure. Again, and thank you to Ipsen for putting this together.
Yes, thank you for all, and hopefully to see you face to face.